This is Walter Kemp. This is Valvular Disease. This first picture is from the plane when I've been flying back and forth to Texas. Just looking down on the rim rocks, the western side of town, around where I live, and that around the airport area. So better than this, as I said. So the Valvular Disease, there are two websites me and Dr. Hughes have for questions for USMLE, Twitter, and I actually logged on this last weekend. So I'm going to start doing that again, getting some unknowns up there. And the reason I put the bottom is I'm a forensic pathologist, so my specialty is forensics, but I have a really strong interest in general pathology, organ pathology, and I think I know a broad range of stuff relatively superficially, which I think makes it good for teaching for medical students. I think I can teach at the level of Robbins, everything like that, without going off into a lot of details and stuff like that. So these are my disclaimers. Please read them. If they apply to you, then stop watching the video. If you want to learn pathology, that's what I want to do. I want to teach you pathology. Disclaimer 3, same thing. Make sure that this doesn't apply to you. And then at the bottom is my introduction if you want to know about my teaching style and everything like that. So far, hasn't been watched a lot, but that's okay. These are the references I'm going to use. I chose in every one. Like I said, these are great books. So we'll start out with a question. So pause, see if you can answer the question. We'll go through at the end, and this helps with retention. So the valvular disease general concepts, for the most part, you're going to talk about the aortic and mitral valve. And it says 2/3 of all diseases affect those. Obviously, when you're talking about pediatric, you can things like tetralogy of Fallot is the pulmonary, the outflow tract in that. So it's not all, but most of it is. So those ones we're going to concentrate on. And usually when you're talking about valvular disease, you either have stenosis or regurgitation. Stenosis is where outflow is blocked. Regurgitation, which is also called insufficiency, is where it leaks. It can develop acutely or chronically. Usually the stenosis usually develops chronically, whereas insufficiency can develop acutely. For example, in a papillary muscle infarct can cause acute mitral insufficiency, or it can develop over time, like for example with somebody with a dilated cardiomyopathy that slowly causes mitral insufficiency. But if you want to think about what would be one form of acutely developing stenosis. So if you had some type of thrombosis or something like that, potentially of a prostatic valve, that could cause acute stenosis potentially. Usually when we think about the valves, I think we think about the leaves or the cusps, but also remember the annulus, especially the mitral annulus, the chordae, the papillary muscle, and other things like that that play a role in the working of that valve. If you have damages to that too, can affect how it works. So basically the 4 categories we'll work on most are aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation. To the right of it, this is a stenotic aortic valve. That's a bicuspid valve. The yellow arrow shows the nodules of calcium in the cusps, and then the white is the midline raphe that we'll talk about with when we talk about bicuspid valves. So aortic stenosis is, for the most part, degenerative. There's 3 types of aortic stenosis. You can get degenerative tricuspid, degenerative bicuspid, and also rheumatic. And we'll talk about rheumatic under acute rheumatic fever and rheumatic valvulitis. So in degenerative stenosis, you get basically nodules of calcium that form usually on the sinus side of the cusp. So the top left shows kind of an early degree of aortic stenosis. The white arrow shows the nodules of calcium. The bottom right shows a more significant, and you can see the nodules of calcium with the white arrows, and in between you'll see a black space. That's actually the lumen. So like I said, one important thing to consider is that when you have a valvular abnormality, oftentimes it's not just completely stenosis, not just completely regurgitation. So this valve to the bottom right doesn't open, basically. It doesn't move. It's so calcified. So it's very stenotic, but because there's a defect there, it's also going to leak. So this person had not only aortic stenosis, but also aortic regurgitation. So with degenerative calcification, usually if it's a tricuspid valve, it's usually around people in the 70s, 80s, whereas if it's bicuspid, it's usually in the 40s or 50s. So there is a characteristic sequence of symptoms. Usually an individual gets angina because of aortic stenosis. They're getting left ventricular hypertrophy. There's more oxygen demands for the heart, and it can't supply them, so they get angina. Syncope, I think I've read on the mechanism of that, but my thought too is just that if you think about just not enough blood flow to the brain, and then congestive heart failure. And I understand it's usually 5 years, 3 years, 1 year for those, but there's got to be some variation. So a bicuspid aortic valve, very common, so I think it's important to know some more details about it, 1 to 2% of the population. And so the black arrow, you can see what's called a midline raphe. Most people with a bicuspid aortic valve, what it is it's incomplete separation of two of the cusps, usually the cusps that correspond to the left and right sinuses, the left and right sinuses, the left and right ostia of the coronary arteries, and it's incomplete separation at that commissure. So it basically looks like they have 3 cusps, but 2 didn't completely separate. It is possible to get a true bicuspid where you have 2 leaflets of the same size, but that's by far less common. And so I remember anybody with a dysfunctional valve can be at risk for endocarditis, which we'll talk about later. And then bicuspid valves can be usually congenital, but can also be acquired. If somebody had endocarditis and you got some fusion at that commissure, it could cause a acquired. So they're usually not considered a cause of death solely based upon the bicuspid aortic valve. Mitral valve prolapse is, but if you get left ventricular hypertrophy, if you have enlarged in the heart, you are at risk for sudden death. So aortic regurgitation, this can be due to damage to the cusps or to the annulus. So infective endocarditis, when the vegetations are growing on the cusps, they can cause them to function abnormally, you get leakage, or they can actually punch a hole in them. With a bicuspid aortic valve, obviously you get abnormal flow because you don't have the normal 3 cusps, and then also as it becomes calcified. Disruption of the annulus. So when we talk about aortic dissection, if that blood gets down the annulus, it disrupts that, and the valve can become leaky. Syphilis, so specifically syphilis causing a thoracic aortic aneurysm, same thing. If the thoracic aorta dilates, it can dilate the aortic valve annulus, and then the cusps don't come together appropriately, and Marfan syndrome. So it's relatively easy for us to see stenosis at autopsy, but not regurgitation. It's tough to tell the functionality of the valves. But there's one thing that we can see, and in the image to the right, the valve actually looks relatively normal, but the person had some degree of aortic regurgitation, because below the one cusp, you can see the yellow arrow, there's that white fibrous bundle there. And what happened is when you have a regurgitant jet lesion, it can hit the endocardium and cause fibrosis. Mitral regurgitation, we'll leave mitral stenosis until we talk about rheumatic fever, because that's essentially adults, the only way you get it. But mitral regurgitation can come from damage to leaflets or the papillary muscles or to the annulus. So to the right of it, this shows a infarcted heart, and the yellow arrow is showing the papillary muscle, and you can see the papillary muscle is yellow-green, just like the myocardium next to it. So this infarcted doesn't have to rupture to cause insufficiency. All you have to do is be dead, and it doesn't function normally. Myxomatous mitral valve can do it, and infective endocarditis, just like on the aortic valve, if the vegetations are growing on it, they're going to affect its mobility, cause it to leak, or they can punch a hole through it. And then if you affect the annulus, like mitral annular calcification, congestive heart failure, dilated cardiomyopathy, you can dilate that, and the leaflets just don't come together the way they should, so the valve is leaky. So myxomatous mitral valve, like a bicuspid aortic valve, are very common. A relatively large number of the population has them. It's to the left. At the top is normal. You can see the leaflets are pretty flat. And at the bottom, you can see the white one shows it kind of curled up like that. The way I kind of describe, and what I use is a kind of, if you were in grade school, I don't know if, what we did was they'd get a parachute, the teachers would, and kids would hold it, and we'd sweep it up in the air, and it would get up to a high point, and it would be like a little tent over us, and we'd run underneath and stuff like that. And so that's kind of the way I look at mitral valve prolapse. So the chordae tendae get long, and they'll slap the endocardium. The yellow arrow is where you see the fibrosis from that. The characteristic clinical is a mid-systolic click, and when I talk about the parachute, that's kind of the way I look at this. You look at the mitral valve is trying to, when the blood is going against it, and finally it just pops up, and that produces that click against the left ventricle, is kind of my way of looking at it. It is associated with Marfan syndrome, although Marfan syndrome, you usually think of the sclerodactyly, you think of people being tall, ectopia lentis, you think of thoracic aneurysms, thoracic aortic aneurysms, but about 25% can have a myxomatous mitral valve. It's not caused by endocarditis, but it could be a complication. You could get endocarditis as a complication of potentially having a myxomatous mitral valve. And unlike bicuspid valve itself, bicuspid valve by itself is not associated with sudden death, but myxomatous mitral valve is. And as forensic pathologists, I've seen people who have died suddenly from association with a myxomatous mitral valve. So I just threw this one in there just so you can kind of see the range of what actually is out there. This is not discussed in Robbins I know of, but the person to the left has a myxomatous tricuspid valve, and the person's right has a myxomatous aortic valve. So the mitral valve is not the only one that can be myxomatous. Mitral annular calcification. This is a disease more commonly of older individuals. Both is from the same heart. The bottom right is a close-up of the same region in the top left where the yellow arrow is. And that yellow that you see there is calcium. So basically, this person's mitral annulus has a ring of bone in it. Literally, it was a ring of bone. You could feel around the entire thing, the circumference of it. And so that's going to affect the ability of the annulus to move normally. It's stuck in one spot, and that's what makes it leaky. Okay, so as I mentioned before, rheumatic fever is strongly associated with valvular disease. Basically, mitral stenosis, there's no other way you get mitral stenosis in adults other than rheumatic fever as a child. And so we'll go through that. So it says it arises in about 2 to 3% of children aged 5 to 15 years after infection of group A streptococcus, which you always wonder about that number if it could be less because it's well known, it's treated and everything like that. But we do see chronic rheumatic mitral valvulitis not occasionally in the older population still. So something to still be aware of. So acute rheumatic fever, you see carditis, which can be a pericarditis, a myocarditis, or an endocarditis. You see migratory polyarthritis, subcutaneous nodules, erythema marginatum, and Sydenham chorea. And chorea is where they make the sudden movements. Lab, they can test for it through anti-streptolysin O or anti-DNase antibodies. And then minor criteria, you can imagine any those would kind of go along with just like in general an infectious type condition and stuff. So, and what happens is the individuals develop antibodies against a bacteria, which in the past has been described as M protein. That might have been changed, but I think if you just understand the concept of it, it develops antibodies against it, but they cross-react with their own normal antigens, which happen to be in the heart. So they usually get about 2 or 3 weeks after the episode of the group A streptococcal pharyngitis. Complications, mitral stenosis, so chronic rheumatic mitral valvulitis, but also aortic stenosis, as I mentioned before, and it's characteristic. You usually get fusion at all the commissures. So acute rheumatic fever, like I said, it can cause a myocarditis. This is myocarditis. It causes what are called Aschoff nodules. It's kind of like a collection of macrophages, other inflammatory cells. And the characteristic cell that you don't see up here very well that I see is at the very bottom, there's one, probably about 630. You see a what they call a Nitschkow cell, which is a caterpillar going across it. So chronic rheumatic mitral valvulitis, the characteristic appearance is you see fusion, thickening, and shortening of the chordae tendineae. So the bottom left is a normal mitral valve. You can see tons of chordae tendineae. And at the top, you see about 5 at the yellow arrow. So there are fusions, thickening, and shortening. The other thing that will be described as a fish mouth appearance, which is in the bottom right. So what happens is because you have mitral stenosis, you get increased pressure in that left atrium. That's going to cause dilation of the left atrium. And then as a result of that, you can develop things like atrial fibrillation and also mural thrombi, which at the bottom right is what you see. There's a thrombus on that left atrium. So even though mitral stenosis is most commonly associated with it, you can also get aortic stenosis. The top left was an individual with aortic stenosis due to rheumatic fever, and both the yellow arrows show fusion at the commissure. So either one of those could look like a bicuspid aortic valve, but it affects both. So if you have all the commissures affected, there's a good chance they did have rheumatic fever as a child. The other thing is this individual had stenosis, but also regurgitation. You can see below it that kind of patch on the endothelium, the black arrow is showing where the jet lesion is hitting it. And for comparison, I put the bottom right, that's a normal aortic valve. Now, they're not quite in the same plane, but I think it still gives you an idea of the pathology there. Okay, so I've had this license plate on my truck for a long period of time, just showing. So anyway, if you want to pause and think about what it is. So anyway, a lot of people was that agricultural surfer? Because you are from Montana. I'm like, yeah, AG is silver. So it's Silver Surfer. It's Silver Surfer from the comic books. And so I'm a real big nerd. So that's me. So this valve, I just saw this valve is like one of my favorite ones for just how interesting it is. So look at this, see how many abnormalities you can identify. And then we'll go on the next one. So this valve is actually trying to be a quadricuspid aortic, but not quite. At the blue arrow, that's actually a midline raphe. So if you compare the commissures, the other two go all the way up. This one doesn't. It's incomplete. So that area of it is actually looking at a bicuspid valve, but it's got 4. So it's actually trying to be a quadricuspid, but it's actually a tricuspid, but one of them did not separate. It also has evidence of regurgitation at the bottom left. You can see that fibrous patch below where the jet lesion is hitting. It's got a high osteal origin, so the yellow arrow is showing that. The ostium should be within the cusp, the ostium for the coronary artery. This one's not. And then I didn't put an arrow, sorry, but there's also some little fibrous strands right in the middle. Those are Lambel's excrescences that you can commonly see. So when talking about valvular disease, you have to talk about infective endocarditis, so inflammation of it. So they describe usually acute and subacute. And now they say that with antibiotics and therapy and other things, there's it's blurred. But I still think understanding the difference between the two can be very useful. So with acute, it's usually a very aggressive organism like Staphylococcus aureus. It can actually punch right through the leaflet. So oftentimes the vegetations are not that big before they're identified. And it can affect normal and abnormal valves, whereas subacute are more insidious organisms like viridin streptococci, things you get from like brushing your teeth, dental procedures, things like that. The vegetations tend to get bigger because they can grow longer, and they don't quite present as acutely and everything like that. So I think it's understanding the two traditional forms can be useful to understanding the spectrum of the disease process. So to the top left, this is a vegetation on the aortic valve, and below that is what the vegetation looks like microscopically. The yellow at the bottom is on all that purple, which is all bacteria, and then the pink around is fibrin. And what you don't see, and I'll tell you there's not there, is inflammatory cells. That's one problem with it, is the valves are avascular, they're out in the blood flow, and so it's very difficult to get antibiotics to them. So with infective endocarditis, the reason it occurs is that when you get abnormal flow, like in dysfunctional valves, things like that, it's possible to get little fibrin platelet microthrombi. And then if bacteria in the blood lodge in those, that can grow up into a vegetation. So people would be at most risk for that would be those who are obviously have immune problems, those who are neutropenic. Cancer is also associated with it. Diabetes, individuals just with diabetes tend to be more, it seems like more at risk for infection in that. And then with infective endocarditis, it can come from dental, GI, GU procedures. So people who have a bicuspid aortic valve have to be on antibiotic prophylaxis when they have their teeth cleaned. And then symptoms, what they'll see is you'll see a fever, obviously an infection in the blood flow. And then you can get a murmur because you get this vegetation growing on the aortic or mitral valve. It can create a murmur. So the complications commonly come from, if you just think of that, you have bacteria growing on the cusp, which can erode through it. So they could perforate it, which could lead to the new murmur or to some degree of insufficiency, even enough to be acute insufficiency. You have a cluster of bacteria that's basically in the blood flow, so that's why they can get septicemic. And then those little vegetations and bacteria can embolize. A lot of things you see associated with endocarditis, splinter hemorrhages, raw spots in the eye. You can see petechial hemorrhages in the skin. You can see hemorrhage in various organs come from those septic emboli landing. You can also see what are called Osler's nodes and Janeway lesions. I had a good image of a Janeway lesion, but I thought might not be completely appropriate to show. But you see little hemorrhage on the hand and stuff like that. And then there can also be immune complex deposition, and they can get glomerulonephritis. And I've actually seen, I have their local myocarditis. I actually saw one, it perforated through the heart underneath the valve and actually caused a hemopericardium. So to the left, this is splinter hemorrhages. This doesn't look like much, but this actually was a person with endocarditis, so these were truly splinter hemorrhages. You see splinter hemorrhages a lot. I did a lot of rock climbing when I was in residency, and I would get some of these, and I'd be worried about my attendings like, hey, you're clinging to the rock wall. It's probably going to do it. So you can see them for a variety of reasons. It's not just endocarditis. And then to the right of it, this was an individual with a septic embolus that caused an intracerebral hemorrhage. Some other associations with endocarditis, tricuspid valve endocarditis. So when people use IV drugs, when they inject the drug, they inject not only the drug, but also bacteria and other stuff. The first valve that comes in contact with is tricuspid. And so when people have tricuspid valve endocarditis, there's a good chance it's associated with IV drug use. That being said, I've seen tricuspid valve endocarditis in people with not using IV drugs, and IV drug use can affect the other valves. So it's not absolute. And then something called rheumatic endocarditis. When I talked about the dysfunctional valve or something, as they become stenotic, and just age related. I mean, with as people age, their valves go through a lot of wear and tear. And even though they're not stenotic or something like that, they're not perfect. And so you can get these little platelet fibrin vegetations that basically grow, and if no bacteria lodge in them, they stay sterile, and that'd be rheumatic endocarditis. So people who are hypercoagulable, people with neoplasia, are more likely to develop those, and you can be pretty prominent. The one I show, there isn't much. It's just with Lambel's excrescence, which is kind of probably a healed rheumatic endocarditis, but I had one when I was a resident. I just unfortunately don't have a picture of it, but just really prominent vegetations that were all absolutely sterile, no bacteria. So when they're treating valvular disorders, I decided to throw these up there. A porcine valve is the top left. That's what it looks like. Bottom right is a mechanical valve. You can actually see they also replaced the aorta. The black arrows show the graft. And then this valve actually underwent dehiscence. It got infected and it broke loose. And the yellow arrow shows the kind of ring abscess. You can see it tearing away from the tissue. So we'll go to the question. If you'll just pause and then answer the question, we'll go through it. So a 53-year-old male presents to an acute care clinic complaining of worsening shortness of breath and exercising. He has not seen a physician in 25 years and considers himself healthy, regularly exercising and a good diet. Physical examination reveals a harsh, late peaking systolic murmur that is heard best in the right second intercostal space and radius of carotid arteries. In addition, the point of maximal impulse is sustained. The second heart sound is difficult to hear. Of the following was likely diagnosis. So I didn't cover heart sounds. So if you only have the lecture, though, you could say, well, it's a systolic murmur, so therefore it can't be aortic regurgitation. That would be diastolic. It can't be mitral regurgitation. That would be diastolic. And it can't really be mitral stenosis because there's no history of an infection as a kid, so it's not very likely either. So it's got to be between the first two. And this is why I tell the students, even if you don't know the answer, cross out the ones that it can't be, and that narrows it down a lot. And then if you look at this 53-year-old male, if you're going to have aortic stenosis and degenerative calcification, it's much more likely to be a bicuspid aortic valve. Okay? All right, so last thing is, like I said, reflection. So go back, think about what are 5 things you learned from the lecture. I hope you've learned 5 things from the lecture. It's been useful. This is a very good technique for helping cement the material, and I don't do a summary slide anymore because that would just not promote doing this. So I highly recommend doing this. Just think back, what did I learn from the lecture? And like I said, I hope you learned stuff from the lecture. And then this is Devil's Tower. This is the northeast corner of Wyoming. My family and I drove through there here recently, and we just stopped, and it looks pretty cool, pretty impressive. So I hope this lecture has been useful for you, and thank you.